Thank you for joining. Thank you for joining us today. We thought it's timely that we talked about the C. diff updates that came out last year from IDSA and the GI Society. It's important because I feel like we're seeing more C. diff all of a sudden, and I'm assuming it's because of all the antibiotic we've been using in the last couple of years. So we wanted to go through it, and feel free to ask any questions or concerns. I'm Dr. V.
Hi, I'm Dr. Horn.
All right, C. difficile update. So just a quick background. C. diff, 500,000 infections in the United States every year, and about 1 in 6 patients who get C. diff will get it again in about 2 to 8 weeks. So the recurrence rate is really high. And about 9%, so 1 in 11 people over the age of 65 who get C. diff in the hospital will die within 1 month. So, I think every time I talk about how high of a risk for dying, especially for elderly patients with C. diff, always our learners are shocked. But it's really important to know that really high mortality as well as you're older. Anything you want to add, Doctor?
No, it's just, C. diff can be very devastating. It can be so bad. And we've had a number of patients recently that just have really bad C. diff. So I think this is really good to discuss.
Thank you. So just a little bit about risks of C. diff. People on antibiotics are 7 to 10 times more likely to get C. diff while on drugs or during 1 month after receiving antibiotics. So that's really high. If you're in a healthcare or nursing home, you're really high risk. And more than 80% of C. diff death occurs in over the age of 65 or older. So that's really important. And one of the other important things, especially our nursing home patients, long-term care patients, they get colonized with C. diff. And anything that disrupts their bowel flora, it takes over really fast. So really important to keep this in mind, especially when our patients are getting asymptomatic bacteriuria treatment, unnecessary antibiotics. So really we have to be careful. Spread of C. diff, so the spores, so hard to kill. Some studies show that spores can hang out for 2 weeks, 3 weeks after a patient is moved and leave the room. So it's really important in the hospital setting, healthcare setting, having good surface cleaning, good hand washing with soap and water, and making sure when we're transferring patients from one hospital to other, letting them know this patient had C. diff. Another really important thing to know is make sure in your facilities when somebody has C. diff, once their stool forms, we shouldn't just take off the C. diff isolation because there's still spores in that room. So it's important to move them to a clean room and clean the room that they were in while they were having the diarrhea with really terminal clean. I would suggest bleach or other cleaning products that kills the spore. Anything else you would add?
No, that sounds good.
And prevention. So improve, of course, antibiotic prescribing. That's what we all do in antibiotic stewardship. Prevent spread, identify and isolate really quickly, gown and gloves, wash your hands really well, and clean the healthcare facilities really well where C. diff patients are in. So here's some data. So we don't have any data for 2021, but we do have some data for 2020. This is released by CDC. Lighter grade of shea is they're doing okay. Darker grade of gray is their more higher rates. And this looks at hospitals and hospital-acquired infections and in acute care facilities. And as you could see, a lot of areas are darker gray. And our goal is to bring it to lighter gray, lower SIR rate getting C. diff in the hospital. So we have a lot of work to do. My fear is though, this is kind of early in the pandemic data, 2020. We've been using so much antibiotics with COVID-19. And personally, anecdotally, I don't know whether I'm seeing way more C. diff right now.
Yeah, I think the antibiotic use has really gotten out of control with COVID. And part of it is that, the patients are so sick and so many antibiotics are started and, if the patient's going to have a bad outcome, people don't want to reduce the antibiotic use, and myself included. It's really hard to de-escalate when you're so worried about the patient. And but I think the other thing is that ID doctors really see a lot of the bad parts of antibiotic use too. We see a lot of, when we see the C. diff patients, we're really reminded about the importance of good antibiotic use.
And if you look over here, again, this is only up till 2020 because CDC has not released the data yet for afterwards. Prior to 2020 and prior, we were doing a really good job coming down with the C. diff rate. 48% significant decrease in SERV from 2015 to 2020. So we were doing a really good job. Unfortunately, I'm not sure what direction we're going to go in now. So we'll see what CDC releases next year. So we'll have 2021 data or later this year. So here's our guidelines. So in 2021, Infectious Disease Society of America did a focused guideline update. Prior to this, they did a guideline update in 2017. With that in mind, this was a focus update because they had new data, so they wanted to make sure they got the information out to everyone. So one of the big changes in 2021 guideline from Infectious Disease Society of America is fidaxomicin. They say patients with initial episode using fidaxomicin rather than vancomycin, it's a moderate certainty of evidence. This recommendation places high value on beneficial effects and safety of fidaxomicin. Depends, but again, they're telling you need to make sure the resources, because we hear fidaxomicin is so expensive. Anything you want to add, Dr. Horn?
No, I think the cost is the one of the major deciding factors of what the patient gets, because fidaxomicin is so expensive, and there have been articles about that too, about choosing which drug to choose based on how well it works, but also in the real world when you have things like cost and things that factor in, it makes it a little bit more difficult sometimes.
Just a little background on fidaxomicin. It's a macrolide class of drug. It was approved in 2011. So prior to that, for 31 years, there was no C. diff medicine. So like a big improvement. What's really nice about fidaxomicin is that it's narrow or spectrum than oral vanco, so it doesn't hurt the gut flora as much. And not a lot of side effects either. And also it's not absorbed systemically. So all those things are good to know, but the biggest factor with it is cost. So in 2017, before the 2021 guidelines, they did two big randomized control trials, best way to design. And back then it said fidaxomicin and oral vancomycin are equal. So it was able to show that fidaxomicin is non-inferior. So it was equal, which was great. But it didn't push anybody to recommend fidaxomicin as the first choice, drug of choice. So a lot of us, like you and I, we've always continued to use oral vancomycin as our first line. And now this is the 2021 guideline, where if you all look here, in patients with initial episode of C. diff infection, should fidaxomicin be used rather than vancomycin? So they looked at for each case per 1,000 patient episode, okay? So sustained response for 4 weeks, they looked at with vanco, much higher rate of relapse compared to fidaxomicin, much lower. With initial cure, a clinical cure, much higher rate of relapse risk but lower with fidaxomicin. So I'm just going to show you right here. So basically what they found in this 2021 study before they released the guidelines is that they looked at large 4 large randomized control studies. They pooled all the data together, and it showed that fidaxomicin increased sustained response of C. diff infection 4 weeks after end of therapy, resulted in comparable clinical cure, but it didn't show any mortality benefit. So still, vanco or fidaxomicin, you still had higher mortality, so more data to follow in that. The evidence also suggested that fidaxomicin did not result in increased drug-related adverse events, which is good. Overall, certainty evidence was moderate because one of the study was unblinded design. So that's why they gave it moderate instead of high evidence. But the big change, because of all these large 4 studies, that's one of the big reasons they changed it as their #1 reason to give fidaxomicin. So this is the new table from the C. diff guidelines. Please ask us if you have any questions because it's a big change. So now the preferred regimen, you want to go through it?
Oh, sure. So the preferred regimen is fidaxomicin, 200 milligrams given twice daily for 10 days. And so, fidaxomicin, fidaxomicin, like PO vancomycin, neither of them are absorbed into the body. They all stay in the lumen of the gut all the way down. But fidaxomicin is 200 milligrams twice daily for 10 days. And the alternative is vancomycin 125 given 4 times daily for 10 days. So both treatments are 10 days. And then the alternative for non-severe C. diff infection, if the other agents are unavailable, then you can do metronidazole. And this is 500 milligrams 3 times a day by mouth for 10 to 14 days. And this is what I was saying, that the fidaxomicin and vancomycin stay in the lumen of the gut. The metronidazole is actually absorbed into the blood, and then from being absorbed into the blood, then goes into the gut. So it probably doesn't get as high levels in the gut as what I would think.
Yeah, and then they also noticed a lot of resistance too with metronidazole.
Oh, for metronidazole.
Yeah, so over 50% to 60% of C. diff is resistant to metronidazole. So honestly, it should be reserved for I don't. So the only times I use metronidazole is when they have very severe infection. I think we're going to get to that actually. Yes, we will.
So, but I only use it in combination with other medications. But here, so fidaxomicin, drug of choice, and then if you can't use that, then vancomycin, and then I would only use metronidazole in combination.
I'm still struggling in the outpatient setting. There's a lot of insurance and patient can't afford it.
Mm-hmm.
So again, it's resource. If you have the resource, go with fidaxomicin. If you cannot, I guess it's still okay to use vancomycin as your primary. But if the patient does not respond to vanco, then really consider transitioning to fidaxomicin.
Then for the first C. diff reoccurrence. So, and also defining reoccurrence, I think, is important because if I see a patient that comes in and was recently treated for C. diff, and they say, I'm having diarrhea, and they were recently treated for C. diff, and they completed that treatment, then the question is, was that a failure or is this a reoccurrence? And so if they come in and they say, I've been having diarrhea and I took fidaxomicin for 10 days and it never made a difference, right? So then I consider that more along the lines of a failure. If they come in and they say, I took fidaxomicin, my diarrhea completely went away or completely got better, and then I did okay for a week or something or a month, and then they come back in with diarrhea, then I would consider that a reoccurrence. Is that how you think of it too?
Yeah, that's really important.
So my first question is, did the medications that they took before make a difference, or did it not make a difference? And so if they improved and then all of a sudden it happens again, I would consider that a reoccurrence. And so here it has fidaxomicin 200 milligrams twice daily for 10 days, or twice daily for 5 days, followed by once every other day until the medication is gone. And that's the extended pulse dose version of fidaxomicin, and that's actually really good. And some people actually do that on the first time as well, just because the evidence for that is actually really good.
Yeah. So like, I think a lot of people don't know about fidaxomicin pulse dose too. So I think just making sure we know this option is there is really important. BID for 5 days and every other day for 20 days.
Yeah.
It's really important to know that.
And it's the same number of pills as the other way of taking it, twice daily for 10 days. It's the same number of pills, so it's the same cost. But in studies, it actually showed to have a lower reoccurrence rate than the other ways of taking fidaxomicin. And it actually has the lowest recorded, I think, recurrence rate so far.
So that's really great. But again, alternative, resource limited, oral vanco taper. So you do that for 6 to 8 weeks. Again, you could do it for 10 days as well, oral vanco. But what's really important is in this yellow box, bezlotoxumab. So we're going to chat about it a little bit. You guys could type in the chat and let us know if anybody has used bezlotoxumab. But what they're saying now is once you have initial and then recurrence, everybody should be getting bezlotoxumab.
Yeah, is that very expensive? I
Yeah.
think it is. Yeah. So that's the I believe that's the monoclonal antibody for C. diff.
Yeah. So it is the monoclonal. We're going to talk about it a little bit. It is expensive, so we'll talk about it a little bit. And yeah, let us know if anybody has used in the chat bezlotoxumab. So now we're going to talk about subsequent recurrence.
So second or subsequent reoccurrence. So you've got the initial time and then first reoccurrence, and then this is going to be second reoccurrence. And so this is fidaxomicin again, 200 milligrams twice daily for 10 days, or twice daily for 5 days, followed by every other day for 20 days. And then you could also use vancomycin in a tapered and pulsed regimen. You could do vancomycin 4 times a day, for 10 days, followed by rifaximin for 3 times daily for 20 days. And the last one is fecal microbiota transplant. So that's a stool transplant. So that's essentially trying to get good flora, good bowel flora in there to overgrow the C. diff with the toxin. So it's essentially another way I like to think of it as fighting C. diff with C. diff, because you're putting C. diff in there, but you're putting C. diff without toxin in there. Ideally, if you can get rid of the toxin producing C. diff, that would be really ideal, I think. And then adjunctive treatment, bezlotoxumab, so that's the C. diff antibody, IV once during the administration. And that's really approved for stopping reoccurrence, I think is the approved indication.
Yeah. So I think, again, taking away that the big changes, fidaxomicin number 1, but if the second reoccurrence, now think about stool transplant. Stool transplants are fantastic. We're going to talk about it a little bit, but bezlotoxumab should also be considered strongly to be given. And then the last but not least, it's when you have really bad C. diff on pressors, hypotension in the ICU, fulminant C. diff. In that case, unfortunately, you have to do vancomycin, not fidaxomicin. So you do vancomycin by mouth, really high dose, 500 milligrams, 4 times a day. You do vancomycin enemas, 4 times a day, 500 milligrams. And then you add flagyl in this case because you're trying to get something. If you have ileus or gut is not working, at least this way, through the blood, it might get something somewhere. So then you add, IV flagyl. But we'll talk a little bit more about opportunities, even with fulminant C. diff, to do stool transplant. So when you have really, really sick patients, it's going to be really important if you can get the patient to a site where there's GI doctors and ID doctors, because I think that's going to be really important.
Yeah.
So this is from 20 older studies that show when do you get recurrent C. diff, right? Like we talked about age greater than 65, high risk, antibiotic, prior C. diff infection, immunosuppressed patient, comorbid conditions like diabetes and such. and if you take gastric suppression treatment. So all of these put you at high risk factor for recurrent C. diff. So these patients, we have to be really careful, right? So now let's chat about C. diff monoclonal. It's really interesting that, when they came up with bezlotoxumab, it targets the toxin B, and that's the, bad C. diff, but they did studies on toxin A, but it didn't pan out as well. So they had toxin A monoclonal, wasn't as good, didn't really do anything, but toxin B was really helpful. That's bezlotoxumab. Again, in these studies, they found out, just like before, recurrent C. diff episode within the last 6 months. If you're really older, 65 and old, immunocompromised, severe C. diff on presentation, multiple risk factors, all these folks should get bezlotoxumab.
Yeah, I think this is going to be used more and more in the future.
Yeah, I'm starting to use it a lot more. The problem is the cost.
Yeah.
And I'm finding the insurance will only cover an outpatient setting and not inpatient. So I'm usually discharging the patients and giving them the therapy as outpatient. Here are some more graphs to support why bezlotoxumab works really well. If you all look over here in this graph, it favors giving bezlotoxumab if you had episode of C. diff with greater than 1 risk factor, no risk factor, doesn't matter, it's still helpful, but you got to weigh the cost and benefit. So then you have to have some guidelines who should get it. So that's what they're saying. And if you had episode in the past 6 months or 2 or more in the past 6 months, again, this very nicely says we should be getting bezlotoxumab. So I think I wasn't using it a lot. I was using more in the outpatient setting. Are you using some, Dr. Horn?
Yeah, a little bit. So it was actually, so it's approved to prevent recurrence in the future, but it actually probably helps also for that current event, right? For that acute C. diff that you're treating.
Yeah, I know a lot of people, we were talking about it the other day.
Yeah.
There's not a lot of studies on it yet.
Right, yeah.
But there's some animal studies with it. So like myself and Dr. Horn have actually given it to patients who are like crashing, fulminant C. diff on multiple pressors. I have actually given bezlotoxumab with everything else. So, in the last couple of months, I've had a few patients who I thought were not going to make it, and they walked out of the hospital. And
yeah, they did better. I don't know, in our patients that we're seeing, that it seems to be working well. I think, and the evidence is supporting it. So that's great.
But let's wait and see, but just be careful if you use bezlotoxumab in hospital setting. Insurance will not pay for it. So you might have to work on them, but for the most part, if you give it in hospital setting, basically the hospital takes the cost.
And our GI doctors have been really good as well. They've been doing, they do colonoscopies, and then they put in the stool transplant that way instead of, I don't know that I've had patients where they have NG placed, or have you had patients like where they do a stool through the NG or through the feeding tube, or pills, where they take like 100 pills or something on the stool?
I think I had a patient with a pill maybe many years ago. I think. But for the most part, patients do not. They prefer.
Yeah, they prefer a colonoscopy, and then they can put it right into the colitis and put the the good flora right where it needs to go, so you're assured that it got there.
Yeah.
And then you're supposed to stop giving medication. You're supposed to stop treating because you don't want to kill that off what you just placed.
That's really important. And here's all the costs. So as you all see, fidaxomicin, bezlotoxumab, depending on your formulary cost status, anywhere between $3,500 to $4,500, or maybe more, maybe less, depending on your formulary status and contracts. But it's really expensive. And bezlotoxumab, it's been okay to get outpatient infusion, but it's been really a struggle to get inpatient. So I have given it in multiple fulminant C. diff, and then we have to just take, the hospital pays it because the insurance will not cover. So that is basically the Infectious Disease Society update. So basically their message is fidaxomicin is number one, really consider stool transplant. And bezlotoxumab should be considered very strongly. Now, this is the guidelines by GI Society. Again, Gastroenterology Society, and they updated it last year as well. And I just picked out some important points from their guidelines. So they really strongly recommend stool transplant for severe and fulminant. If you saw in the IDSA, they didn't recommend stool transplant and fulminant, but the GI Society does. And we have been doing that. So it's really important if somebody's doing really bad with C. diff, transfer to an area. If you have GI ducts, that's great. Otherwise, let's transfer so they get stool transplant.
Yeah, I think, and colectomies for C. diff can be very bad. They can have a very high mortality.
And I have the patients that we've seen, they looked like they were going to need colectomy and they did fine afterwards.
So this is a fecal transplant should be considered for the treatment of severe and fulminant C. diff unresponsive to standard medical therapy. And a single fecal transplant resulted in cure. So this is 66, between 66 to 91% of patients in case reports. So, and if you look, stool transplants, when you compare, how well they work and lowering the recurrence rate, the stool transplants really, I think, are the best when it comes to reoccurrence and preventing reoccurrence.
Yep. And so I want to kind of highlight something that they showed in this guidelines. We want to highlight something, and it's Dr. Fisher et al. Dr. Fisher from University of Indiana, and he does something really cool where, and our GI doctors and us, we have been doing, Dr. Horn and I have been doing this for a bit. When somebody is really badly fulminant C. diff, they will give antibiotic, they scope, they do stool transplant. If the patient has pseudomembrane, when they do stool transplant, they'll go back in again about 3 to 5 days later and see if the pseudomembrane is resolving. If not, they'll transplant again. So some patients, like, that elderly patient we had, I think she got 2.
I think so.
Yeah. She got they went in again, they saw pseudomembrane, they transplanted her again, and they went in again and was okay, so they stopped. So we have been, so this is a really good protocol. It's part of the GI guidelines. So in protocol, a patient with severe fulminant infection who failed to respond to 5 days of oral vancomycin, 6 days of metronidazole therapy undergoes stool transplant using a colonoscopy. If the pseudomembrane is present, oral vancomycin is restarted 24 to 48 hours, and subsequently, another stool transplant is done at day 3 to day 5. I have had patients where we have done 4 stool transplants. Was a little while ago, and this patient walked out of the hospital okay, but it was very severe. So this protocol is really good. They mention in the GI guidelines, and if you all need to look it up, his name is Dr. Fisher. From University of Indiana.
Well, so this is the Open Biome project. So this is where they, here it says, we work with clinicians to make fecal microbiota transplantation easier, safer. So, they're who I believe collect the stool.
Yeah.
They I think sell the stool.
Pre-screen the stool.
Yeah, pre-screen the donors, which there are people that donate their stool. They get tested. They try to make sure that they're not going to pass anything on, and then donate their stool, and then it's frozen in capsules or however else in bottles and things. And it's good that they're doing this and making it available, so the places that want to do this can do it easier than in the past. They used to get family members to donate stool and things like that. But there is kind of a gross factor here that some patients. I had a patient I think just last week that said he didn't want to even talk about this because it sounded gross.
Yeah.
And
it might, but
it might save their life. Yeah, it might save his life. Yeah.
Open Biome is awesome because back in the day, we used to get family members, screen them for all HIV, hepatitis, and everything else, and then we were able to transplant, but this is pre-screened stool, frozen stool we have. The only problem was during COVID-19, they had some issues. So now you have to contact them, and it takes about 24 to 48 hours to get the sample. So I think the cost is about $350. So I think that's really affordable for a procedure to do stool transplant that's pre-screened for all the infection. So I think it's a good process. But yeah, if you need for somebody, you have to make sure you call them about like 24 to 48 hours to get the pre-screened stool.
This is secondary C. diff prevention. So this is oral vancomycin prophylaxis can be considered during subsequent systemic antibiotic use in patients with a history of C. diff. So if a patient comes in, they have a history of C. diff, they had C. diff, whether it was moderate or severe, they had a history of C. diff, and then you're giving them antibiotics that can cause a reoccurrence of C. diff. You're giving them antibiotics that have, that are known to cause C. diff that can be bad. You can consider giving vancomycin while they're getting those systemic antibiotics. And so you'd give it with the antibiotics they're getting. So say a patient has an infection, whether it's osteomyelitis or it's a joint infection, and they have a history of C. diff, you can, while you're treating that joint infection, give them also PO vancomycin. And then you'd continue that PO vancomycin while they're on the antibiotics for their infection. And then you would continue it for another 5 to 7 days after stopping the antibiotic for their infection. So you're essentially trying to prevent them from getting C. diff again. You're, and this is something I do. Is it something you do as well? Yeah.
And I think we have been doing this for many years now. Yeah. So I think a lot of ID docs, we were always are so afraid when a patient has C. diff, they come back and now they have pneumonia and we're giving them So we have always put them on oral vancomycin prophylaxis, like twice a day for 5 to 7 days after stopping. But it's really nice to know it's in a guideline now because it wasn't anywhere before.
And the most common diarrhea when you give antibiotics is just antibiotic-associated diarrhea. So that's the diarrhea, that lots of people get when you start antibiotics. You're killing off a lot of their flora and they just get diarrhea. But when you stop the antibiotics, that should stop and go away. But it's especially worrisome in patients that have had C. diff in the past, and they say they're getting some diarrhea with the antibiotics you're giving. If they've had C. diff in the past, I do give them vancomycin with them and with it. And remember, the vancomycin is not absorbed into the bloodstream. It stays in the lumen of the gut and hopefully kills off, a lot of that C. diff with the toxin and tries to prevent it from happening. And that's what I would want if I were in their situation. So that's why I do that.
And this is a really nice study. They combined 10 observational study and they looked at over 99,000 patients. And what they saw was future recurrence of C. diff in patients who received vancomycin prophylaxis versus patients who didn't. Patients who received vancomycin prophylaxis had lower rate of recurrence compared to patients who didn't had a higher rate of recurrence. And it was statistically significant as well. So this is part of the GI guidelines that encourage you to give secondary oral vancomycin. So it's 125 twice a day until you finish the UTI treatment, pneumonia treatment, and then 5 to 7 days after.
So, and this is only in patients that have had had C. diff in the past, and that's why it's secondary prevention. Yeah.
And it's another way of nicely looking at these 9,000 people study. Every single study favors giving secondary oral vancomycin to prevent recurrent C. diff. So we have been doing it for a while. I know it's not a big practice in some places, but now there's data and it's in the GI guidelines.
Yeah. The other question we get from patients, they'll say, they may say that they've either had C. diff in the past, or they've had a friend that had C. diff, or they've heard about it, and they ask about taking probiotics. And probiotics is a good question. I think that there have been some meta-analysis and things, and the evidence for it isn't great. So sometimes they'll show that it helps a good number of people, but sometimes it's not statistically significant, but then you get into discussions of what is statistical significance anyway. So when patients ask me or when we talk about it, I'll say, it might help, but it won't hurt.
Yes.
And so, if it were me, I might be trying everything I could to stop, what's going on and trying to get good flora there. So the evidence for it, while it's not great, but some people do find a benefit from it. So,
I think there was a study maybe 8 years ago or something. It was a big randomized control study, and they looked at probiotics. And they looked at a subgroup. There was a benefit in people who took lots of different kinds of bacteria in large amounts. So like just taking a lactobacillus pill wasn't doing it. It's like, eating yogurt with like lots, 6 different bacteria, large colony forming units, or that drink kefir that has like 12 different bacteria with lots of bacteria quantities might be helpful. A lot of times I know patients ask me, can I just take a pill? And I know in our lab, our microbiologist has taken those pills and tried to grow the bacteria. Half the time they're all dead. So you're just giving money away for no reason. So I really think eating yogurt or kefir is a good way to go.
Yeah, I think in each hospital, there are several different probiotics. I think there are 4 major ones, and they're different amounts of lactobacillus usually, or different. It might be one strain or several strains, and I think each hospital kind of decides which probiotic they want to use. And there is some evidence kind of for those. There are some good articles that kind of go through the evidence for probiotics, and it's also probiotics is also kind of supposing that the food we eat, that we never eat bacteria unless it's in this little pill or something. Like I'm sure we eat a lot of bacteria all the time, right?
Yeah. I don't know if it's good ones.
Yeah, I don't know if it's the kind you want to coat your gut with, right?
I really encourage my patients to eat yogurt or drink that drink.
Right, and it might help. It might help and it won't hurt, right? That's exactly how I see it. Yeah.
So this is an update finishing. So what we take away from this talk is that fidaxomicin is not moved up. That's number 1. But think, are you in a resource limited area? If the patient cannot afford it, insurance will not cover it, then you're still stuck with oral Vanco, but fidaxomicin is preferred. Number 2, second time you get C. diff, third time you get C. diff, really consider giving monoclonal antibody for your patient. Inpatient, it's not covered, so give it as outpatient when they're leaving. Fulminant C. diff, severe C. diff, please consider getting stool transplant and making sure there's a GI doctor that can help the patient. And lastly, oral vancomycin prophylaxis can now be given if they recently had C. diff for the last 6 to 12 months. They're high-risk patients with past history of C. diff.
Okay, great. I think this is a great update on treatment of C. diff, and I think it's very important that you try to follow the latest things, and I think this is great. Does anyone have any questions about this at all?
Yeah, we're happy to answer. You could unmute. Okay, there's a question. What method do you have implemented to guide providers in appropriate C. diff testing? Oh, that's really good. So we have the 2-step method as IDSA is recommending. So we do the 2-step method and finally to confirm if it's toxin positive or not.
Yeah, looking at antigen and then looking at PCR for the toxin, C. diff toxin. Yeah.
So we have the 2-step method instead of just the 1-step method.
Right, and then as far as testing in the future, I would just go off of symptoms. So if their symptoms are improving and they've been treated, I wouldn't do any further testing to show that they've been treated, because they might remain positive for a long time.
That's really important. So don't retest. If their stool is formed, you're treating them, no reason to retest for C. diff. Because when the stool is formed, the good bacteria is taking over and the C. diff is just getting part of that population. If you see it retested, it'll be positive. So don't retest while you're treating. If the stool is formed, you're good. Have you ever seen a small adaptive use deficit? Are you getting reimbursed for inpatient use? So far, not a lot of people are using deficit. We are getting inpatient reimbursement, but you have to be careful. But so far, we are seeing we're getting reimbursed for inpatient, but we are having outpatient issues with deficit. So it's case by case.
There's a question about, and then this is for testing all cases of diarrhea. Well, if we're going to test a patient, when they first come into the hospital, we want to see, does it sound like it's C. diff, or if they have a history of C. diff? And if we want to test, ideally we would test early. Is it, I think, before?
Well, if you test them after the third day of hospitalization,
at midnight, I think, right?
Yeah, it becomes a hospital acquired, right? And a lot of times what we find is patient comes in with watery stools, nobody tested them until third midnight. So that means, on the 29th, if they at 28th, they came in at yesterday at 11:50 p.m. That's 1 midnight. Today's second, and tomorrow's third midnight. If we don't test it before that, and if you do it after, then it becomes hospital acquired. And in the hospital setting, we're testing sometimes too late, which means we're spreading it in the hospital, spreading it to other patients, spreading it to healthcare workers. So really important to have high degree of suspicion and test immediately when they come in with a watery stool.
Yeah, so put them into isolation and test them early so it doesn't become a hospital, or it doesn't go down on the books as a hospital acquired pneumonia. And as far as the diarrhea, it depends on the suspicion and if you think it's C. diff or not. If you have another reason for them to have diarrhea, then I wouldn't also test for C. diff, or if they've been on laxatives, or if they've been taking something that would give them runny stools, then I would recommend not testing. And usually when there are issues with testing, like with C. diff, it's because the tests aren't great. And whenever there's an issue with testing and it's hard to tell if something is real or not, it is generally when you run into issues with especially who to test and things.
Yeah, I really like what you said about laxatives, stool softeners, tube feeds. These all cause watery stool. That's really important, is that's what's causing it. If not, and they have fevers, leukocytosis, clinically they look not well, then it's okay. And sometimes, they order C. diff and they had like 1 diarrhea. Usually that's not C. diff. C. diff patients are having like 10 stools a day, uncontrolled, watery. I think history is going to be really important too. Any other questions, concerns, comments? Well, thank you so much. We really appreciate it, and we'll see you guys next month.
All right. Thank you, everybody.